cập nhật rất là mới về viêm gan thoái hóa mỡ không do rượu, về cách chẩn đoán cũng như là cơ chế hồi sinh và điều trị. Thì xin trân trọng kính mời giáo sư Grobenfish.
Xin chào quý vị. Tôi đến ở Việt Nam 10 lần. Bao nhiêu tại tôi lần trong tháng sọc đàn ở Việt Nam. Xin chúc mừng bạn tôi chúc bạn tôi gần thành phố Hồ Chí Minh. Tôi chúc phúc hấp thành công. Xin cảm ơn. I'll now speak in English. Nói tiếng Việt. Mất vậy. Tiếng Anh. So I will talk today about fatty liver, NASH, and what is going on in the clinic today. So I practice and see patients in California, Nevada, and Arizona. And I also practice via telemedicine and telehealth to many parts of the country, of the US, and also many parts of the world. So I see NASH from a world perspective. You've heard much today about how these different factors interact to cause fatty liver. Then I really focus today on what you can do in your clinic with your patients, how to treat and how to prevent this global epidemic of 120 million people with metabolic syndrome, and 80% of those patients have some form of fatty liver. 30% of the US population has fatty liver as well, and a smaller number have NASH. What I'd like to highlight on this slide is a request for you in your practice to make sure that you have the liver enzyme, GGT, as part of your laboratory tests for each liver patient. GGT is one of the liver enzymes. It is not a liver function test, but GGT is very useful for determining liver disease and also prognosis. The GGT test helps predict who will get cirrhosis and also predicts cardiovascular disease and cardiovascular mortality. So GGT in the clinic, from a practical perspective, is very important. Every patient with elevated liver enzymes, ALT, GGT, AST, alkaline phosphatase, needs one quality ultrasound at baseline. And we'll talk more about ultrasound testing in a few moments. This is a very big problem as our society has evolved. Stronger, 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 and now lung, right? So this is an epidemic that we're facing. The next few slides I will move through quickly because this is telling you a story of 1987 in the United States and an emerging epidemic of obesity and metabolic syndrome. Red is bad in this map. Obesity, metabolic syndrome. And by 2014, we now have half the country at this very high rate of obesity, in some states over 35%. This is being driven by multiple different factors: behavior, environmental, and genetics. And we'll talk about how you can use those in your practice today. You've heard much today about the comorbidities on the left, but I want you to think about the new associations on the right, including thyroid disease. Each liver patient with NASH should have a thyroid panel. You need to assess your patients for sleep disorders. The obese patients get sleep apnea, they get reduced sleep quality. We'll talk about that in a research study in a moment. We need to think also in men and women about pituitary function, and in women about polycystic ovary syndrome, and work with your endocrine colleagues. So this is a very interesting conspiracy, we think, in the United States, with now internationally selling sugar. Sugar is addictive. Sugar drives hunger, right? You're hungry, you eat more, you're driven to eat more sugar, and it's an endless cycle that is now driving fat accumulation, liver disease, NASH, inflammation, and fibrosis. So in the United States, they are now starting to tax soft drinks. Last week in the United States, one major city put a sugar tax. That tax will go back to helping the health of the community. We're hoping the whole country will have a sugar tax and then have that money come back to help patients. Fructose is the evil spirit in this situation. We need to have a low fructose diet. No soft drinks, minimal sugar supplements in our diet. Vegetable diet, low meat diet, low fat diet. Now I want to talk about one other item. Each of you are drinking out of these special bottles, right, at your table. These bottles contain a chemical called bisphenols, BPA. If you look at the bottom of your bottle, you'll see a triangle that has a number 1. This number 1 indicates the plastic has bisphenols. The bisphenols have been shown in a research study at Duke to change DNA methylation. The DNA methylation changes insulin resistance, changes fat storage. This is both in the patient and in the offspring. So France, Canada, and now the US is restricting or eliminating this type of plastic from people's diets. All my patients with NASH are told not to drink out of plastic, only to drink filtered water in special bottles. It could be glass, metal, or new special plastics that are bisphenol free. So think about this as something in your clinic that you can change with your patients today that's evidence-based, at least from animal studies, with human studies starting today. What about ethnicity? We've heard much today already from my 2 colleagues about NASH in Asia, NASH in Vietnam, but we're going to go back to the United States, and we see this big discrepancy with a high level in African Americans and blacks, middle in whites, and low in Hispanics. Something in the genetics that are very important here, and genetic testing is now emerging in the clinic, and I, as of this next week, will be ordering a blood test on my NASH patients called PNPLA3. This PNPLA3 gene polymorphism predicts inflammation and predicts fibrosis. It's not perfect. There's at least 4 other polymorphisms that are associated with NASH and fibrosis, but PNPLA3 is the strongest predictor of inflammation and fibrosis in NASH, ASH, which is alcoholic liver disease, and also hepatitis C. So we're going to start making our medicine personalized, testing genetic risk in my patients who are PNPLA3 positive. I'm going to be more aggressive about interventions. A little bit more about Hispanic, Caucasians, African Americans. It's a little bit different study where now Hispanics were higher than Caucasians in terms of prevalence. So this has something to do with behavior, region, and genetics. So we are our environment. What we eat every day, how we take in food, and in our food we have some special food, chua, right? Yogurt. In yogurt is a natural probiotic. All of my patients in my clinics who have NASH are on probiotics daily. Inexpensive, low price, obviously yogurt, chua, or you can spend a little bit more money and get probiotics in packages or capsules. My favorite in the United States is VSL3, and I supplement my patients with NASH twice daily with probiotics. I think this effect is much greater than herbal remedies, although the herbal treatments may be helpful as well, but probiotics are changing the biome in our patients. This, I believe, is evidence-based because the microbiome modulates insulin resistance and metabolism, which you've heard about today. You can change the microbiome by losing weight, or you can change the microbiome by taking in probiotics on a daily basis. This is diet therapy. Obese patients before special diets had a bad microbiome, and as they are compared to lean controls, better, more favorable, anti-inflammatory microbiome. So I definitely in my clinic am measuring lipids, I'm measuring insulin and calculating HOMA-IR, hemoglobin A1C, fasting glucose, and profiling my patients with these simple laboratory tests. These are much easier to do than doing a liver biopsy, even though biopsies often provide a large amount of information. You've heard today about insulin resistance and NASH. This is just a reminder that you can check fasting insulin levels, calculate glucose, calculate your HOMA-IR, and use that to help motivate your patient to change their behavior. Behavior modification is the key for treating patients with fatty liver. Fatty liver is predominantly a behavioral disease. Many companies are coming out with pills. We're sending our patients to surgeons, but if the patient loses weight, liver is more healthy, less inflammation, less damage, less risk of liver cancer. I do want to comment for a moment about liver cancer in my patients. We have now data that patients with fatty liver without cirrhosis can get liver cancer. 1/3 of liver cancer patients with NASH do not have cirrhosis. So now we have a dilemma. When do we start screening? I'm afraid my pointer is okay. See it? When do we start doing screening and surveillance for liver cancer? In NASH patients, definitely cirrhosis, but I'm now starting surveillance in F3. How do we find out scoring in fatty liver? We go online on the computer and calculate a NAFLD score. It's free. Put in some laboratory information, and you get a fibrosis score that's at least 85% accurate. You can combine that with other testing that we'll talk about shortly. Then you educate your patient about starting liver cancer surveillance before the patient gets cirrhosis. You're going to think about HCC surveillance in F3. This is giving you numbers of risk of progression, which you've heard about today. You've also heard about histology and the importance of histology. But we can't biopsy every patient who we think has NASH. So we need to figure out fibrosis, inflammation, and also we have non-invasive testing, such as the FibroScan machine, which is available in Vietnam in multiple locations. FibroScan now has an FDA approval for fat calculation called CAP, Controlled Attenuation Parameter. It's a software add-on to the FibroScan machine. So FibroScan, short time, can calculate fibrosis. It's the best machine to calculate fibrosis, simple machine, in fat patients other than magnetic resonance. The FibroScan has CAP, Controlled Attenuation Parameter, that can then calculate your percent fat in the liver. So what about NASH? What have we learned? So people have simple steatosis, no inflammation, low risk of both liver-related mortality, overall mortality. But now, once we have inflammation, the risk becomes much higher. We go from 2% to 9%, and then once they have cirrhosis, that mortality risk even goes higher. So in each of your patients, you can calculate the presence or absence of cirrhosis, also by simple testing. You have a blood test. You ask on every ultrasound. Every time you send a patient for an ultrasound, you ask for the spleen size. You ask for the portal vein diameter. If the spleen is over 12 centimeters, portal vein over 12 millimeters, that patient then is predicted to have cirrhosis, 85% accuracy to 90%. That patient needs an endoscopy for varices. That patient needs to start liver cancer surveillance. You need to know the stage of that disease to determine next steps and also further education on behavior modification. So we've talked about obesity, glucose. Of course, you're going to have blood pressure on all your patients. You're going to look at their lipid profile, cholesterol, triglycerides, but as you heard today, you want to know LDL and HDL as well. In addition, I'm calculating on my NASH patients C-reactive protein, CRP, a marker of inflammation, also helps you predict risk of progressive disease. So this multiple hit hypothesis that you've heard about today is important. We don't measure cytokines or adipokines in the clinic, but you can measure simple markers of inflammation, such as SED rate or C-reactive protein. And what I want to emphasize here on this slide is that you're going to find low-level autoantibodies in some of your patients, such as a positive ANA or positive smooth muscle antibody or high iron tests. But this is a normal byproduct of the liver inflammation. It's very rare that a NASH patient will develop autoimmune hepatitis or iron overload. You can, of course, calculate iron in the liver without a liver biopsy using MR scanning and calculating percent or quantitative iron using a technique called T2 star that your magnetic resonance radiologist can have a special software. They get a picture of the entire liver iron and determine if they need to have phlebotomy, such as a problem here in Vietnam that might be beta thalassemia. Check the iron saturation. You can check autoantibodies, but low-level F-actin, low-level ANA are not clinically important. We're going to tell our patients to drink zero alcohol. This is very, very important that we remove ASH from NASH. There is no safe level of alcohol consumption in patients with fatty liver. So zero is the best. This requires your time and your education. Physical exam, you're going to feel the liver, see how large the liver is, but you're going to move quickly to simple imaging modalities as we talk to you about ultrasound. You want a quality ultrasound reading about liver texture. We mentioned also the spleen and portal vein, the left lobe size, the caudate lobe size, the surface of the liver. And you can get this information also from CT or MR scans. So we talk about progression of NASH, but we're not biopsying patients sequentially, but you can do imaging sequentially. And if the laboratory tests are changing, the spleen is changing, the liver configuration is changing, you need stronger interventions in the clinic to motivate your patients to change their diet, lose weight, and increase exercise. Again, I want to decrease the importance of biopsy unless you think there's another confounding disease in those patients. You might do a biopsy to look for increased iron, autoimmune, alpha-1, Wilson disease. There are other conditions that can coexist with NASH, including some rare storage diseases, such as liposomal acid lipase deficiency. But these storage diseases are rare, typically seen in children or young adults. The histology becomes important in those cases to look for glycogen in the liver, to look for fat type, such as microvesicular fat. But this is really going to be important, maybe 1, 2, or 3% of your patients. Ultrasound we talked about. There are serum fibrosis markers that are available also commercially that probably are about 70% accurate and I think are not helpful in those patients. I'm typically using imaging, simple blood tests, and calculations such as the NAFLD score. But what's coming in the future are some exciting biomarkers such as the CK18 fragments. This CK18 test will probably be commercially available in a short time. And of course, as you can see, you have all these other scores, most of which can be done off laboratory testing or imaging. Occasional tests can also be done through a blood draw for a moderate cost. I do want to emphasize that MR elastography is the ultimate and best test, but unfortunately it's much more expensive and time-consuming. But that MR elastography is the standard that will be used for approval of many of the new medications for NASH as we decrease biopsy use and understand that these bigger, better imaging technologies assess the whole liver, not one tiny piece of the liver, such as the liver biopsy. A little bit more information about the importance of liver enzymes, insulin, HDL, and some specific biomarkers. Again, the C-reactive protein and the numbers here are emphasized in terms of predicting inflammation versus no inflammation. C-reactive protein is a test that might cost less than $1 to have that test run. So biomarkers, we talked about these from a clinical perspective, and the data from the EASL guidelines that were published just a few weeks ago are giving these A to B quality, and in some cases C quality information. So blood biomarkers are still not ready for prime time. A little bit more information on CK18 fragments. There's a lot of overlap between normal, fat, and NASH patients, but very high levels of CK18 can predict progression or presence of advanced fibrosis. As people are treated, such as the PIVENS trial, remember the PIVENS trial used pioglitazone and vitamin E, you can see marked declines in these biomarkers of fibrosis on treatment. This is just showing a picture of ultrasound right liver, echo texture, and you can calculate a ratio of the liver echo texture to the kidney Although in our practice, where Dr. Hui-Chin and I in San Jose have tried this, we haven't gotten very high quality information. Publication looked great, real life, I'm not so sure, but you can at least think about calculating a ratio between liver fat and the renal or kidney characteristics, ecotexture. CT scan, qualitative, not quantitative, in terms of suggestion of fat. Fat can also be focal. You get fatty sparing, or you can get fat accumulation in specific parts of the liver that may look like a liver tumor, may look like liver cancer. So you need to be very specific with your radiology partners looking for the characteristics of these tumors to make sure you're not telling a patient that they have cancer when they have some fat accumulation or fat sparing. Remember, the standard today for liver cancer is not a liver biopsy. The standard of care is not alpha-fetoprotein. The standard of care to diagnose liver cancer is CT or MR using a special scoring system called LIRADS, L-I-R-A-D-S. Your radiologists should all be using LIRADS in liver patients who are at risk for liver cancer. LIRADS, I can send you more information, but this is very important that you get a LIRADS reading or score from 1 to 5 if there is an abnormality or tumor in a liver of patients with cirrhosis or even chronic liver disease. Just a little bit more about histology. These Mallory's-Hyland is classically described in alcoholic liver disease. If you do a liver biopsy, your pathologists say you have a Mallory body. You don't necessarily go back and accuse the patient of drinking. You just go back and take a detailed alcohol history. They're not drinking alcohol. This Mallory's-Hyland is due to the NASH, not to alcohol-induced fatty liver. Just more pictures of different variations. Definitely need this trichrome stain. Your pathologist should be giving you details on pathology, including something called the NASS score. So ballooning, inflammation, and fibrosis are specific descriptions on each liver biopsy if you actually biopsy your patients. So let's talk about interventions. Well, we've talked about some important things already. Eliminating bisphenols from your patient's diet. I don't drink out of these bottles anymore myself. I lost 30 pounds. Maybe it's because I quit drinking this, or maybe because I'm eating less. But we need to use a multi-combination approach to intervene with our patients. Eat less, exercise more, no alcohol, no fructose, very important steps. But what about antioxidants? Vitamin E data from the Pivens trial was very good, but that was a non-diabetic population. Chris Cowley, a very famous liver doctor in the United States, has the meta-analysis he'll publish showing vitamin E is useful across all patients with fatty liver. But you must use a special vitamin E. There are two types of vitamin E. One, natural D-alpha, that's plant-derived. This is the vitamin E that works and is safe. The other vitamin E comes from petroleum, from oil. They pump out of the ground. They actually get vitamin E out of this oil. This is the bad vitamin E that increases the risk of prostate cancer in men. D-alpha natural vitamin E I use for all of my NASH patients, all right? I'm giving you the formula. Exercise, eat less, no bisphenols, vitamin E. Vitamin E dose, 800 IUs per day. If they have cardiovascular disease, I lower the dose to 400 international units per day. We are going to fight insulin resistance. The data on metformin is good, The data on metformin for preventing liver cancer is also good, at least B quality. So in my fatty liver patients who have NASH, I support their diabetologist to be using metformin 19, which is a special growth factor that also changes hepatic inflammation, insulin, and lipid metabolism. So beta-cholic acid, I think works, but may be too expensive to apply to most of our patients. This is the Flint study that led to the approval by the FDA for a large phase 3 study, a large number of patients, well-profiled, and the FDA and the NIH halted this study early because the improvement in histology was so significant between the drug and placebo. The unfortunate thing about a beta-cholic acid is that it increases LDL slightly and decreases HDL. This may be an unfavorable lipid change in our patients. The phase 3 study will determine whether that is important or not. Other lipid-lowering agents have been looked at, and I want to emphasize on this slide that my favorite is pravastatin. The different statins, pravastatin has the lowest risk of drug-drug interactions. Pravastatin at 20 milligrams per day has the lowest risk of muscle inflammation or myopathy. So if you're going to use a statin, which I recommend in your NASH patients with lipid abnormalities or NASH patients with cirrhosis, you should choose pravastatin, and the dose would be 20 milligrams per day. Liver transplant for NASH. This is a very sad story. In the United States today, 20% of our liver transplants are being done for NASH and fatty liver-induced cirrhosis. This is a behavioral disease, of course, with environmental and genetic influences, but what an expensive treatment for something that we may be able to prevent by early intervention, by you in your clinic managing these patients. So as I finish my presentation, you have to think about NAFLD as not a liver disease, but as a systemic disease. The largest number of patients with fatty liver die from cardiovascular events. TIM, right? Inflammation of the heart and vessels. Number 2, cause of death in NASH patients is cancer. Different types of cancer. Obesity drives cancer, not just liver cancer, but many different types of cancer, including breast cancer, colon cancer. So by losing weight, patients can decrease not just their liver disease, but their heart disease risk and cancer risks. Diabetes, of course, increased risk for a number of these, as you've heard today. This statement that biopsy is required. Well, it's required for research studies, but in your clinic, you're going to biopsy very few patients because you have many other tools. Not smoke, stop alcohol. But let's talk about the best herbal remedy in the world. You have some outside this door in those nice silver cans for free, and that's coffee. Coffee, it's an herb, it's a plant. Anti-inflammatory, anti-cancer, improved survival, decreased overall mortality rates. Coffee and green tea have shown excellent data that these are part of your management of your patients, provided that they don't drink so much coffee they can't sleep, right? So weight loss, moderate exercise, vitamin E. I'm going to cross off the pioglitazone. Consider fatty acids. The statins are safe and I think a key part of management. I want to close and just give you information that in 4 weeks I'll be back in Vietnam with my partners for a meeting here, starting a screening program in Ho Chi Minh City for viral hepatitis B and C. This is in partnership with HASL partnership with a number of clinics, including Medic Clinic here in Ho Chi Minh City. We're going to screen 500, then 5,000, then 50,000, and more patients over the next 5 years. The screening program is starting today in Ho Chi Minh City. After lunch, I need to leave for about an hour to go do a site inspection of one of the screening sites. And my partner, Dr. Glenn Dao from Dallas, Texas, is leading VVHA, Vietnam Viral Hepatitis Alliance, which is in partnership with the city of Ho Chi Minh, the Department of Health, Public Health, many providers. You will be hearing more about this in the very near future. World Hepatitis Day is just 4 weeks away. And I have some great partners, Dr. Paul Kuo, Dr. Stephen Harrison, who have helped me and educated me about NASH. Thank you for having me come to this wonderful meeting, Ho Chi Minh City, Hassel Organization. Your enthusiasm, your support. Xin cảm ơn you.
Thank you very much for your beautiful speech. Bây giờ chúng ta đã xong cái phần hội thảo, thì chúng ta còn cái phần tiếp theo là thảo luận. Thì chúng ta sẽ có khoảng nửa tiếng để thảo luận các cái câu hỏi mà chúng ta sẽ đặt ra cho các bạn báo viên. Thì riêng đối với lại giáo sư Kim Khuê thì giáo sư Lê có bận việc, thành ra có thể những cái câu hỏi nào liên quan đến cái chủ đề của giáo sư Khuê thì chúng ta có thể là gửi lên lại cho ban tổ chức, chúng tôi sẽ truyền tải lại.